Hello, and welcome to Bite Size MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on pneumonia under the section of respiratory medicine. So I'm sure that all of you listening to this would know what pneumonia is and would have dealt with clerking a patient and looking after a patient with this condition before. However, as a recap, you generally have three types of pneumonia: bacterial, viral, and fungal. And the other way to categorize this is based on the location that the patient has been infected. So you can either have a community acquired pneumonia or CAP, a hospital acquired pneumonia or HAP, or sometimes you can have an aspiration pneumonia, which we will be discussing in future videos. For the purpose of this video, we will be concentrating on community acquired pneumonia or CAP. Community-acquired pneumonia is the commonest cause of annual hospitalization in the UK amongst adults. It's more common in the elderly and in patients who are immunosuppressed. The common pathogens will be followed in the following slides. However, the commonest way that clinicians in the UK try to risk stratify this condition based on the British Thoracic Society is with the KERP 65 score, which is C for confusion, and that's an AMTS or abbreviated mental test score of less than 8. Urea more than 7, respiratory rate more than 30, blood pressure, a systolic of less than 90 or a diastolic less than 60, and an age of greater than 65. So you can have a total of 5 as in a maximum to 0, and the higher your number, the more likely it is that you will require hospitalization and the higher the rate of mortality. So we will be talking about different types of community-acquired pneumonia based on the offending organism. The first one, which is the most common type, is Streptococcus pneumonia, which is a capsular polysaccharide antigen which can be detected in the serum, sputum, pleural fluid, or urine. Very commonly, it could potentially be a PACES case, which you will have a patient that has a herpetic cold sore and are presenting with a case of pneumonia. And the commonest antigen in those cases will be Streptococcus pneumonia. You will have your generalized pneumonia symptoms, which is your constitutional symptoms, which includes cough, breathlessness, potentially confusion in the elderly, as well as pyrexia. And obviously the confusion, for those of you who have an interest in geriatric medicine, would know that sometimes confusion, especially in the elderly, can lead to hypo or hyperactive delirium. The second type of organism that can lead to the development of community-acquired pneumonia is Mycoplasma. Typically, for MRCP purposes, this would be somebody who is a young adult, and sometimes in your textbook you will be learning about the name walking pneumonia. And that is just to say that the patient normally looks quite well and is a young patient, and this pneumonia can have a long prodrome. It can take typically between 2 or 3 weeks, and during those time patients are normally generally quite well. And the other thing for part 1 examination is that it can lead to a positive cold agglutinin test in half of the cases. There are quite a few important extrapulmonary manifestations associated with Mycoplasma pneumonia, which include erythema multiforme, peri or myocarditis, erythema nodosum, disseminated intravascular coagulation or DIC,
thrombocytopenia, hepatitis, pancreatitis, and cranial and peripheral neuropathies. The picture on the right side of the screen is supposed to show erythema multiforme, which are these dotted red lesions across the skin. The next type of pneumonia that we will be talking about is Legionella. Legionella is one of the organisms that is not too uncommon in real clinical practice and is one of MRCP favorites. So for the purpose of MRCP, this would be somebody who is generally middle-aged to an elderly patient that has essentially been in contact with contaminated water, air conditioners, or shower systems, and it affects male 3 times more than females. The other key factor is that the antigen for this type of pneumonia is only detected in the urine. Our other type of organism that can lead to a case of community-acquired pneumonia is the Staph aureus, which is frequently followed by viral illness, and it has quite a high mortality. It is more common in intravenous drug users. As you guys know, this is an organism that's quite common on the surface of the skin, and not too infrequently, you will realize that the patient has evidence of abscess on the chest x-ray. So in terms of the investigations for a potential case of community-acquired pneumonia, as you would with any other condition in medicine in general and for the purpose of MRCP, you would be starting with your history and thorough clinical examination. On examination, you would be picking up signs such as reduced chest expansion and breath sounds on the affected side. The side of the pneumonia will be dull on percussion, and you will frequently hear coarse crackles. Then you would move on in a systematic order to your bedside observations. So your confusion, your respiratory rate, your blood pressure, which can help you to calculate an abbreviated KERP65 score without urea. Then you would be asking for sputum sample and culture to try to target your antibiotic treatment. Then you would move on to having some blood tests, including inflammatory markers and renal function. At the same time, it would be really important, especially if you are considering possibility of sepsis, to ask for blood cultures and lactate levels. In order to help you correctly identify the antigen, you would also ask for urinary antigen specifically to Legionella and pneumococcal disease, and you would also be asking for viral swabs including COVID, flu, RSV, metapneumovirus. These normally come as a package in many trusts in the UK. You would then move on to radiology, and the first thing that you would be starting with is a chest radiograph, which can show you the evidence of consolidative changes. And then you can consider a pleural aspiration, especially in the case of a parapneumonic effusion. We will be talking in more details about pleural effusion in one of the future videos. The management of community-acquired pneumonia really is surrounding the correct identification of the organism as well as the correct choice of antibiotic. And the decision for admission depends on the severity of the disease as well as your clinical judgment. So sometimes you may have a patient with a KERP65 of 0 or 1 that, according to the national guidelines, they wouldn't necessarily need admission. However, if they are particularly immunosuppressed and or elderly and vulnerable and confused and wouldn't be able to cope on their own at home, then it would be completely reasonable to have the patient admitted. However, generally, a single choice of antibiotic agent should be used for outpatient treatment, and intravenous antibiotic as per your trust formulary would be required for inpatient treatment. In many trusts, this would be a case of quamoxiclav and clarithromycin or quamoxiclav and erythromycin. The treatment duration is typically around 7 to 10 days. However, it can be up to 3 weeks in the case of Legionella. And it's really important that you ask for a repeat chest x-ray after about 6 to 8 weeks of admission to make sure that there is complete resolution of the consolidative changes on the admission chest x-ray. This is because that if the consolidative changes are still non-resolving, then it would be really important to consider and potentially have the patient worked up for a possibility of diagnosis of lung cancer. Okay, let's do some questions. A 65-year-old gentleman presents to A&E with acute worsening shortness of breath with a cough productive of green sputum. He came off a flight from Lanzarote 48 hours ago, where he had been staying in an air-conditioned rented apartment alone. On examination, he has a temperature of 38.5 degrees and reduced air entry on the right side of his chest. He's requiring 4 liters of oxygen via nasal cannulae to maintain his saturation at 96%. Given the likely diagnosis, what is the causative agent? So the options that you've got are A, Haemophilus influenzae, B, influenza, C, Streptococcus pneumonia, D, Legionella, and E, Staph aureus. And going back to the clinical vignette, it is a really classic case of somebody who is a middle-aged man who's presenting after coming back from holiday and staying in an air-conditioned place, and is presenting with a diagnosis of pneumonia. Hopefully all of you had clicked that this is a case of pneumonia, and given sort of the phenotype of the disease in the clinical vignette that's been described for you, you would realize that this is a case of Legionella disease.
Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.